Okay, so good evening. Welcome to the third webinar about skeletal anchorage in the palate. And today I like to speak about rapid maxillary expansion and class 3 treatment. And I like to speak about how palatal TADs can help us to make a class 3 treatment of children and of adults more successful, more effective. And I will start with young kids, treatment of growing patients. But at the end of my talk, I will also speak about adult patients and rapid maxillary expansion and class 3 treatment of adults. So sorry, I have a cold. But I try to speak clearly and slowly. So if it comes to early class 3 treatment, we usually start with a Frankel appliance, and at the age of maybe 6 or 7. But as soon as the patient is a little bit older, maybe 8, 9, or 10, we are using the face mask because it is, of course, much more effective. Usually we are combining the face mask with RME, with a rapid maxillary expansion device. And everybody knows the reason for this. As soon as we are doing rapid maxillary expansion, we are at the same time stimulating the midface sutures. And if we have this midface suture stimulation, the advancement of the maxilla is probably more. However, this is discussed controversially in the literature, but most papers, most research studies recommend to combine face mask with rapid maxillary expansion. So this is one patient treated in our university. We used a face mask in combination with a dental-borne expander, a Hyrex expander. And this combination, again, is worldwide used very frequently. The class 3 is a moderate class 3. And so we did RME. She has worn the face mask. And we saw some advancement of the maxilla. However, since the forces are applied to the dentition, the teeth are going to move. And if the forces are applied using a face mask, the teeth are going to move forward. So we always have a certain amount of anchorage loss. But usually we don't want to move the teeth. If we want to use the face mask, we want to just protract the maxilla. So usually this dental side effect in terms of mesial migration of the teeth is unwanted. So in this case, because of this anchorage loss of the dentition, we had to remove the upper first bicuspids, but usually we don't want to remove them in class 3 patients. So the goal is to avoid dental side effects. So this usually happens if we are using a face mask, the maxilla comes forward, but also the teeth are moving forward. And this effect is round about 50%. There are many studies about this out, published over the last decades. And they found out, yes, face mask has an effect, but only half is skeletally and the other half is dentally. But in most of the patients, we don't want dental movements. So this dental-borne RME device has some anchorage loss in terms of mesial migration, but also tipping, buccal tipping of the teeth, because the forces are in the transversal dimension, and thirdly, extrusion of the molars. So we usually see these three side effects: mesial migration of the dentition, tipping of the teeth, and wide opening. So this is why I'm here today. I like to discuss with you if skeletal anchorage can help us a little bit to avoid these side effects. So as you know, and we talked about this in the last two webinars at the University of Düsseldorf, we love to use mini implants in the anterior palate. They help us in many situations. And we have published the combination of mini screws and teeth many years ago. It's called hybrid Hyrex. Yeah? That was the first paper, 2008. After that, we have published at least 15 papers about the hybrid Hyrex. It's a combination of mini screws, two mini screws in the palate, and more or less two molars or two deciduous molars. And this is used for rapid maxillary expansion and can be used for rapid maxillary expansion in combination with class 3. Nowadays, there are other colleagues followed our ideas. Maybe you know Won Moon. He's now very popular, and they followed and published this 2014, 2015. He calls it MAPE, but it's more or less the same. I don't like it too much, to be honest, because the mini screws are inserted in an area where you don't find enough bone. Okay, so in this area where these screws are inserted, the bone is usually very thin, so it doesn't help too much. So my recommendation, if you want to do the hybrid Hyrex, choose an area where you find enough bone, and this is more in the anterior area. We talked about the T in the last two seminars, and you find this in many cone beam CTs, many cone beam CT studies. This is the best area for mini implants because there you find enough bone. An Italian group called it SCAR3, published this last year. I don't know why they found a new name. It's more or less the hybrid Hyrex. We tried many things with just mini implant borne expanders using 2 TEDs or 4 TEDs. So the T-zone can be added using this area between 5 and 6. However, it's always a bit risky because you can touch the and damage the dentition. So if you want to insert mini screws between 5 and 6, it's recommendable to use these insertion guides. This is, for instance, a quad expander, and the mini screws are inserted after vertebral planning. And if you have a cone beam CT, this is not a big issue. You find best insertion sites for your mini implants. Transfer this using the printed insertion guide and then you can insert the mini implants and fabricate the quad expander. The good thing, you can insert the screws and the expander in just one appointment. So I think this is the future for our technicians. Sorry. So you see a nice, just mini implant borne expansion, and the teeth are not tipping or anything. This is another case. Again, virtual planning and transfer using the insertion guides. And especially a little bit older patients, you have a good chance that you can still open the suture without tipping off the teeth. But today I like also speak about early class 3 treatment. And for early class 3 treatment, you need class 3 hooks. Okay, so we are still using teeth. From my point of view, it's not so super smart to add hooks here for the face mask, because then you will touch more or less the dentition, the teeth. So if you want to add hooks for the face mask, we are still using the molars and coupling it with mini screws, and we are adding the hooks right here buccally, because it's much more comfortable for the patient, like this. So for class 3 patients, we are still using the hybrid Hyrax. The goal is we want to avoid mesial migration, and the force should be transferred to the bone, and because we more or less want just skeletal reactions and no dental side effects. So we only want the maxilla to come forward, and again, we don't want the teeth to move mesially. So the goal number 1 is in the sagittal dimension. Goal number 2 is in the transversal dimension. And we don't want tipping of the teeth. And we can achieve this goal. Why? The force is applied a little bit higher, and we don't use bicuspids. So the hybrid Hyrax serves 2 different goals. First, in the sagittal dimension, if we want to correct the class 3, and secondly, in the transversal dimension, because we see less tipping of the teeth. So there are a number of studies published. I don't want to show you too many papers, but just some of them and the main take-home messages. This is a study from Turkey, and Dr. Kayala, he measured a conventional expander and compared it with a hybrid Hyrax. He found out tooth-borne devices led to excessive tipping, whereas the mini implant-borne devices moved the first molars more bodily. Hybrid devices, so with mini implants, showed less dental periodontal side effects. Next study, published from the University of Örebro in Sweden, and they compared conventional expander with a hybrid Hyrax. If it comes to nasal airflow, and interestingly, if you're using mini implants, you will see a better improvement of the nasal airway flow. So maybe you can decrease the risk that our young patients get mouth breathers. Is it more painful? And I think this is the most interesting study. published by the same group in Sweden, and they compared conventional expander with hybrid Hyrex expander. And interestingly, they found out using mini implants there's less pain. And I think everybody expects it worse, vice versa. So why sorry, is there less pain if we are using mini implants? The reason is the forces are not applied to the anterior dentition, so more or less the teeth are hurting. If you apply a high force to the dentition, the teeth are causing pain. If you have mini screws, the pain is interestingly much lower. So interesting take-home message from my point of view. Again, we talked about the T-zone, and this is the best site for the mini implants. And please don't insert them like some doctors do using this MARP device, because in this area the bone is very, very thin, and I think they don't help you so much. Yeah, you can insert posterior, but then you have to stay nearby the suture. So the clinical procedure is as follows. 2 mini implants are inserted in this T-zone, stay distally from the rugae. This is the conventional approach. We talked in the last 2 seminars about digital approach, but this is the conventional approach. Then you have transfer caps and laboratory analogs. And you have transferred the situation, the intraoral situation, to a plaster model. Yeah, not so difficult. And the technician is manufacturing the hybrid Hyrex on a plaster model, similar to a manufacturing of a conventional expander. And this is after insertion, after fixation of the hybrid Hyrex expander. Again, here you see the clinical procedure in the video. Apply some anesthetic solution. In patients that are afraid of a syringe, you can also only use topical anesthesia if you want to. So it's not a big thing. Yeah. So from my point of view, this is a very easy procedure. If you stay posterior from the rugae, it's a very relaxed insertion site. Again, this is the conventional approach. In the conventional approach, we are first inserting the mini implants. Take an impression. We are using silicone impression. And after a couple of days, the appliance comes back from the laboratory. Then we are going to fix it on top of the mini implants. If you have done this a couple of times, it is as easy as fixation of a conventional expansion appliance. Okay, but we see many advantages. We are mostly using light curing cementum. Why? We have a little bit more time to fix the appliance properly. So I like to show you now some patients. A young class 3 patient, moderate class 3, which is minus 5.1, and this is the hybrid Hyrex in place. You can use, as mentioned, the milk molars. Why not? If the roots are still in a good shape, you can expand now and start with a face mask immediately after 10 months. You see in this case, a nice improvement of the class 3. And the good thing, no dental changes, just a skeletal response. This is the reason why we are using the mini implants. Now it's almost class 2. And this is our main goal, because in the next years, the mandible will grow. So overcorrection is always recommendable. Which change in this patient was 6.6. And yes, we measured the effectiveness of the hybrid Hyrex. This is one of the first papers we have published about it 9 years ago. And we measured before and after 3D scans. And we wanted to know, do the molars really stay stable? Because we don't want them to move. We just want the whole maxilla to come forward. So again, I like to repeat this because this is so important, frequently more. So question, and the answer is yes, they stayed stable. Only 0.3 millimeters of movement, so clinically they were very stable. No molar migration. Next study, we measured using cephalograms before and after, and we measured the distance from point A to the trifurcation, and the take-home message is again, no molar migration also in the cephalograms. So no migration in the scans, no migrations detected in the cephalograms. Another study we have published with Lorenzo Franchi. He's one of the world leading experts if it comes to class 3 treatment, early class 3 treatment. This was published in the Angle Orthodontist. Effectiveness of maxillary projection using a hybrid Hyrex face mask. And we have compared with an untreated control group. Again, this is the most important point, no dental side effects, so no molar migration. And also, this is very interesting, less vertical dental side effects. So the risk of bite opening is also lower. And this was very surprising for us. We didn't expect this before, but of course it's common sense. The molars are fixed with the mini implants in the palate, so they cannot extrude. And this is a major risk and the reason for bite opening if you are using a face mask. Okay, so at the end we have 3 different advantages of the hybrid Hyrex compared to conventional tooth-borne expander. No mesial migration in the sagittal dimension, less or no tipping of the teeth in the transversal dimension, and no or less extrusion and less risk of bite opening. And this is very important, especially in vertical patients. Which improved 4.5. So another study published by Peter Nahn, is one of the other class 3 experts, world renowned class 3 experts. And Peter Nahn has compared the tooth-borne versus the hybrid Hyrex borne appliances in combination with the face mask, and he found out hybrid Hyrax minimize dental side effects. This is our main goal. And again, no vertical dental side effects, so the risk of bite opening is much lower. So Peter Nahn's recommendation was use or insert the mini implants, especially in patients that are vertical, because the risk of bite opening is much lower. So how about the severe class 3 cases? How can we maybe get as much effects as possible? And there is a protocol, probably you heard about it, the Alt-Ramic protocol. And we are doing this Alt-Ramic protocol in every young class 3 patient where we need as much maxillary protraction as possible. So probably you know how this Alt-Ramic protocol is going. The maxilla is expanded for 1 week. In the second week, the maxilla is made smaller again, compressed. In week number 3, it is expanded again. In week number 4, it is compressed again. So this is a procedure over 8 or 9 weeks. And the idea behind it is a longer stimulation of the midface sutures. And the more stimulation of the midface sutures you have, the more maxillary protraction we expect. This is what it's all about. And the question is, of course, how much does this Alt-Ramic really help? Yeah? And this was the first paper that was published by the Italian group around Lorenzo Franchi 5 years ago. And they measured a conventional expander with face mask versus expander and Alt-Ramic, so pumping the maxilla. And they found out if you use Alt-Ramic, you get more maxillary protraction. So additionally, we see an SNA improvement of 1.2. Doesn't sound much, but as we all know, class 3 cases are more or less always tough. Sometimes we have the risk to get edge to edge. So 1.2 as an average, it should be used from my point of view. Width appraisal, 1.6 millimeters. So this is additionally, okay? So usually get maybe width approval if the face mask is worn properly by the patient, usually get maybe 3 to 5 millimeters of width approval. But if you are using Alt-Ramic protocol, you will get 1.6 millimeters more. So take home message out of this study, we should do this in every patient where we want to get as much maxillary protraction as possible. Over the last years, there were some other studies, and they all told us the same story. Alt-Ramic helps us. Yeah? So even if you don't use mini implants, my recommendation is to use Alt-Ramic if you want to get as much protraction as possible. I think nothing can happen. We are doing this in our university since maybe 10 years on a regular basis, and I didn't see any problems yet. So my strong recommendation, do Alt-Ramic. So, but if you want to be as effective as possible, we talked about this, without dental side effects, it seems recommendable to use the hybrid Hyrex together with Aldramic. So from my point of view, this is a turbo for early class 3 treatment. So we are pumping the maxilla, expanding, constricting, expanding, constricting. And due to this expansion and constriction combination, we see a very good stimulation, a loosening of the sutures, the mid-face sutures, and it's much easier to protract the maxilla. In some patients, you can even feel that the maxilla is getting a little bit looser. What is very good. Yeah. So I like to show you now some patients where we did the hybrid Hyrex with Aldramic and in most of the cases with a face mask. Width minus 8.2, so quite severe class 3. Of course, we always have to check the functional shift. If there's a functional shift, this helps us. Okay, so this is a rule of thumb. Please check the functional shift if you have a crossbite. Hybrid Hyrex in place. Start with expansion, second week constriction, and application of the face mask. Yeah. I know Eric Liu very well, and Eric Liu is expanding, constricting for 8-9 weeks, and after this time he's starting the face mask. But I don't see a reason why we should wait until the end of Aldramic. So my recommendation, you can start with a face mask from day one. Why not? So 8 weeks or 9 weeks depends on what is the desired final transversal status. Do you want to expand? Do you want a wide maxilla? The last activation will be expansion. If you want the same transversal width of the maxilla as before, the last activations will be constriction. So at the end, it maybe you didn't change the transversal width at all, but the Aldramic helped you a lot to stimulate the mid-face sutures. So he was wearing the face mask properly, and after 9 months, which has improved to minus 1.1, and the approval was 7.1. So quite a lot. Before and after, nice skeletal improvements. Again, we are avoiding dental side effects. Another patient. We did RME and Aldramic. This is after maxillary protraction, and you see the nice improvement. Before minus 8.3, after 0. So very impressive improvement of the class 3. Well, not all patients are so compliant because you need, of course, face mask wear time if you want to get so much improvement. Okay, but what is also very impressive, have a look at the inclination of the upper incisors. They are uprighting. Yeah? And of course, this is only possible if you use skeletal anchorage. If you use dental anchorage, you will see more proclination of the incisors. So very important. This is the patient when she was finished with her orthodontic treatment. So wear time, I talked about this, is a very important thing where we have to take care of. We have to motivate the young class 3 patients. But we have tested something. We wanted to know if it's possible to measure the wear time. So we have integrated a small electronic chip into the frontal bar of the face mask, and this device is called Theramon. Maybe you know it. Usually it is used for removable appliances like a Schwartz plate, but we integrated it into the face mask because we wanted to know and motivate our patients. If you can tell your patient, wow, you have worn the face mask just 5 hours, please try to improve. Yeah? And if they improve, you can measure it, you can evaluate it, and you can say, oh, we have improved. Last month, you have worn your face mask maybe 9 hours per day. And then you can say, wow, we have done a good job. So I think it's a very good motivator for our young patients if you measure the exact wear time. So this is a hybrid Hyrax in place. You see expansion and the patient is wearing the face mask. Always try to go for overcorrection. So if you have a nice overjet, it's very good. Before and after, width approval 4 millimeters, so quite as an average. His mean wear time was almost 11 hours per day, so quite a lot. He had a lot of fun with his face mask, but this is not very typical because we have some patients that are not so motivated. For instance, like this young lady, and you see the wear time was very disappointing, very low. Many days, like here, where she didn't wear her face mask at all. A little bit motivated here. But of course, if you have these wear times that are so short, you will not see good results. So the question is there an intraoral alternative to the face mask? And can we offer something to our patients who don't want a face mask? And can we use mini screws or maybe mini plates? And the answer is, of course, yes, there is an alternative. We tested a lot. This is, for instance, a patient of mine. I think I've treated him 14 years ago. And in the upper arch, hybrid Hyrax is always super. I recommend it strongly. But again, we talked about the face mask, and the parents said, my boy is maybe not so super motivated for the face mask. So we tried something else. We used 4 mini screws in the lower arch, coupled them, and applied class 3 elastics from here to there. Okay, goal is always to get just skeletal effects and no dental side effects. Okay, so problem was all 4 mini implants failed. This is a lesson we learned over the last 20 years. In young patients, the failure rate of screws that are inserted in between the roots is very high, much too high. Why? Because in the last months or 1.5 years, these teeth have just erupted. Okay, so the canines, the first bicuspids, have just erupted short time ago. That means the bone in this area is not mature. It is not dense enough. This is the reason why failure rate is very, very high, especially of buccal inserted screws in young kids. So as a rule of thumb or as a take-home message for you, don't insert buccal mini screws in young kids. You feel it. If you insert them, the bone is not dense, the failure rate will be too high. So from my point of view, this is a no-go area. So mini screws between the roots, not a good idea from my point of view. But what is the better idea? Can maybe long mini implants help us? This was a paper published by Carlos Villegas from Colombia. Yes, maybe they can help, but I don't think that these very long screws are comfortable or have a good survival rate. There was a very, very good idea by Hugo de Klerk. Maybe you saw a lecture of Hugo de Klerk. And Hugo de Klerk, he's, as you know, he's from Brussels. And Brussels is just 1.5 hours away from Düsseldorf. So Hugo was visiting our department 12 years ago when he came up with his mini plates. And he's using 2 mini plates in the lower arch in the anterior area and 2 mini plates in the posterior area. And he is applying class 3 elastics. So primarily, I think this is a very smart idea. Yeah, and force can be applied 24 hours, 7 days a week. And it's more or less for those patients who don't want a face mask, from my point of view. Hugo is telling us it's much better compared to face mask. I don't think so, to be honest. It's just an alternative. So we always have to be honest from my point of view. Yeah. So, but as an intraoral alternative, I think it's a very smart idea. So we tried around about 10 cases of these 4 plates in our university. And in these 10 cases, we saw some disadvantages, some problems of the Hugo de Klerk approach. First of all, we talked about the midface suture stimulation. And if you don't have an expander in place, of course, you don't see the midface suture stimulation. You cannot expand, and probably at the end, we see less skeletal effects. So we are giving away the chance of this aldramic midface suture stimulation effect that gives us additional skeletal improvement. Big disadvantage from my point of view, we have to wait until the lower canines are erupted. Why? The lower plates cannot be inserted before the lower canines are erupted. So the patient is maybe a little bit too old for early class 3 treatment. The patient is maybe 12 or 13, so at the end, probably too old. Risk of failure. We had many failures of those plates. Um, and then you have a problem with the parents, I can tell you. 4 plates, especially the upper plates, have a very high failure rate, more than 25%. This is a study for many surgeons. It's more interesting to read the studies from the users and not from the inventor. Okay, so forget the papers from Hugo de Klerk. Read this paper published last year in this journal. And you see the failure rate is quite high. 25% of the patients suffered failure of one of the mini plates, and then you have to make another anesthesia. Failure rate is very high in the maxilla, 6 times higher. So we learned this. Forget mini plates in young kids in the maxilla because the bone is not dense enough. And mini implant failure is especially high in young patients. So this is the age on the X years. So at the age of 9, 10, the failure rate is 60, 50%. Half of the mini plates were lost. So wow, of course, this is a failure rate that is much too high. So we had similar experiences. So we skipped inserting mini plates in young kids in the maxilla. We don't do it anymore. So this is one of the patients I treated with the 4 mini plate approach from Hugo de Klerk, and I saw an additional problem, risk of root damage. So please have a look at this. Please have a look at this area. Yeah, we are very close nearby the canine roots. And after removal of the plates, you see that the surgeon has damaged the roots. So this is another disadvantage of these mini plates. So we learned our lesson. We are not using these plates anymore. And our idea was plates are good, but not in this area and not with this high failure rate. So we moved to a more safe area, and this is a mental area, because in this area you are away from the roots and you find a very high bone density. So we are not using 2 plates anymore. We are just using 1 plate, and this is called mental plate. And this plate I can strongly recommend to you. We are using this plate in early class retreatment for those patients who don't want the face mask. And we are using this plate also for patients who need mesialization in the lower arch. So missing lateral, missing second bicuspids, missing first molars. This mental plate is very reliable. We have inserted around about 200. Failure rate is 0. All of them were stable. So very, very stable area. So in young class 3 patients, this is our approach for those patients who don't want a face mask. We are using the hybrid Hyrex in every class 3 patient. Why? Less dental side effects and more skeletal effects. We are doing expansion or alt-Ramek. In the lower arch, we have a small surgery. Make this flap, insert the mental plate. Mostly we are using 3 or 4 fixation screws. And after 1 week, we are starting with class 3 elastics. The good thing, we can start earlier. We can start at the age of 8, when we have the best age to treat a class 3. So this was our first patient, treated maybe 10 years ago, with a class 3, minus 8.3, so quite a class 3. And we talked to the patients and the parents, and this patient said, no, I don't like this face mask. I prefer the plate. It's a small surgery, but no problem. I don't want this face mask. Okay, so we went for the mental plate in the lower arch and the hybrid hyrax in the upper arch. 24 hours of force application. We can start with 200 grams. And if the patient gets used to it, you can get a higher force up to 400 grams. Yeah. And again, we can start before the canines are erupted, so you don't have to wait for the canines. Yeah, you can start at the best age, which is 8 or 9 years. Yeah, this is a patient after 8 months. By the way, there's a nice textbook from Peter Nahn. It's an ebook if you want to download it. It's a nice overview over early class 3 treatment. So minus 8.3 to minus 2.8. She has worn her class 3 elastics properly. And you see at the end a nice approval of the profile. And again, she was our first patient, so she turned now 17. And yeah, it looks very stable. So for this patient, we have avoided a later surgery. Another patient where we use the hybrid hyrax in combination with the mental plate. Again, you can start at the best age. This is a different design of the mental plate. We called it T mental plate. Advantage, you just need one cut here, so a smaller flap. Disadvantage, it is not so stable. So we had some failures of this T mental plate. So we are not using this nowadays anymore. But it worked out fine in this patient. This is after removal of the hybrid hyrax. Nice improvement of the skeletal structures. So we published some papers about the effects of the mental plate. If you want to read it, this is one of the papers. Similar skeletal effects compared to the face mask. So mental plate is as effective as a face mask, so it's not better in the sagittal dimension. So width improvement was more or less similar, but it was better in the vertical dimension, interestingly. Okay, so mental plate has, compared to the face mask, two different advantages. Advantage number one, you don't need extra appliances. And advantage number two, we see less vertical effects. Yeah? So in this patient, I've shown you, you see improvement of the the mandible arch angle. And the reason is, using the face mask, we have more or less a retrusive force and the risk of a bite opening change in the vertical dimension. On the other hand, using a mental plate, we have a retrusive force, so you have a better chance that the bite is closing. We have compared the hybrid Hyrax in combination with a face mask or mental plate, and we saw skeletal anchorage with the mental plate in the mandible provides a greater vertical control and might be the treatment of choice in high-angle patients. So this is the take-home message. We have two indications for this mental plate. First indication group is if the patient don't want face mask. Second indication group are very vertical patients because we have a good chance that we can close the bite due to the biomechanical force application. So I have a small video about the patient.
So
and
first
she
of
had
all,
mental
how
plate.
old are you, Marietta?
9 years old.
9 years old. Okay, you speak English pretty well. Why?
Because my dad and my sisters Emilia Magdalena and I'm a Canadian and my dad.
Really? Oh, that's
Yes.
pretty interesting. Okay. So you have a new orthodontic appliance in your mouth.
Yes, I do.
And what is the reason for this orthodontic appliance? You know what this is all about?
Yes, because my
Upper jaw.
upper door
Upper jaw. Yes.
upper jaw they it has to go to the front.
Okay. Good. So you know it pretty well.
Yeah.
So you used to wear this face mask. We call it the Lair mask. A
Yeah.
couple of years ago.
Yes.
And how did it go with this face mask?
Well, I didn't like it so well because the one thing where I had that finger here,
Yes. Chin cap. We call it chin cap.
yes, and it also hurted a little bit, so I didn't like it.
Okay. So right now you have a new appliance. When would you start with this appliance? What time did we start to put it in? And since when are you wearing it?
I have it like 1 month because we started to put it in January the 31st of
Okay.
January.
Okay. So you know it pretty exactly.
Yes, I
Okay.
do.
So maybe you'd like to show me your appliance. Is this all right for you?
Yes, it's
So
okay.
this is in the upper jaw. Please put your head a little bit to the back. Yes, like this. And open your mouth a little bit more. Perfect. And how about in the lower jaw? Yes, please show me your little plate. No, I don't see it pretty well. Just like this. Yes. A little bit more. Yeah, just wait a second. We see it right here. Yes. And you are wearing right now these elastics.
Yes.
And what do you think it is? Did it hurt after the surgery, or how long did it hurt after?
A little bit. It hurted. It hurted like after the operation a few days.
Few days, okay. And was it a big problem for you, or did it hurt pretty much? What do you think?
The first and the second and the third day it hurted pretty much, but then it got better.
Okay. So right now, 4 weeks later, it's okay for you?
Yes,
And
it is.
would you, after all, to sum it up, would you recommend this treatment approach for other children, or what do you think about it?
I think I would investigate the other children, the plate and the other,
The
the
screws.
screws.
Okay.
and the elastic bands because
It's much better.
well, it helps pretty much, and when you have it like a few days and more, like a month or a half, then it doesn't hurt.
Doesn't
You're
hurt
getting
anymore.
used to it.
Yes, I'm getting used to it.
Okay, fine. Okay, Marietta, after all, thank you very much.
You're welcome.
It was quite a pleasure to talk to you and wish you a very nice day and see you next time.
Bye-bye.
So you see, it's not a big thing for the patients. Of course, you have a small surgery, but after a couple of days, it's okay for them. So let's have an overview over the possibilities for early class 3 treatment. Everybody knows the conventional expander with face mask. To be honest, this is my favorite approach, the hybrid Hyrex and the face mask, because it's not so invasive. Just 2 mini implants, which are, from my point of view, not a big thing, but very effective. For those patients who don't want a face mask, sorry, you can use the hybrid Hyrex and the mental plate. And additionally, we have vertical improvements and the 4 bollard plates from Hugo de Clercq. So if we want to summarize, of course, on the left side, we have no surgery, 2 mini implants, 2 mini implants and 1 mini plate and 4 mini plates. But if it comes to efficacy, on the left side, it's not so efficient because we are moving the dentition 50%. And as soon as you are using mini screws or mini plates, the efficacy is much higher, less dental side effects and more skeletal effects. How about treatment in our hands? I personally like if I don't have to send the patient to an oral surgeon, and the patients maybe are also not so happy if they have to go to a surgeon. So I like if the treatment stays in my hands and as an orthodontist. And I think as soon as we are using just mini screws, we as orthodontists can do that. As soon as it comes to mini plates, it's more or less a job for the surgeon. How about the failure rate? Failure rate is very low if it comes to mini screws in the palate and the mental plate. Failure rate is much too high from my point of view if we insert plates unilaterally in the maxillary retromolar area. How about RME and Aldramic? Is it possible? As soon as you have an expander in place, expansion and Aldramic is possible. So I like to use a combination with an expander. So in our department at the University of Düsseldorf, we are using at the end only these 2 approaches for our young class 3 treatment. Again, both are quite effective. And in most of the patients, we are using the face mask. In some patients, we are using the mental plate, again, for those non-compliant patients who don't want the face mask, and in very vertical patients. So how about the design of the expander in special situations? I like to give you some clinical tips. Hybrid Hyrex is now used worldwide, and not just in class 3 patients. And it's one of my favorite mechanics. So I like to show you some additional tips in these special situations. So after expansion, sometimes you want to remove the expander because you want to continue with the orthodontic treatment. And there's a good chance that we can apply a skeletal retention. And we are just using the Bennett plate, squeezing it a little bit. So now we have a skeletal retainer in place. Okay. So after expansion, you should leave the expander for at least 6 months in place. But again, sometimes we want to remove it earlier, or maybe the expander is broken. Yeah, so you have to remove it earlier. My tip, use this plate as a skeletal retainer. How about those cases where we want to distalize the molars? This is happening from time to time. So you want to protract the maxilla, but in the second phase, you want to distalize the molars. Yeah? So orthopedic treatment, protraction of the maxilla, and orthodontic treatment, distalization of the molars. So for this two purposes, we can use two different mechanics. Two appliances approach. First, hybrid Hyrax. Remove the hybrid Hyrax, leave the mini screws in place, and use them, the same mini screws, afterwards for distalization mechanics. You know this patient from the interview. She was before quite severe class 3, as you can see right here. Yeah. And this is how she has shown up in our department. I don't know why she had 2 brackets in place. She was under treatment at another orthodontist, but I think the orthodontist was afraid because of the class 3. So she needed maxillary protraction. So we did this with the hybrid Hyrax and the mental plate. But after maxillary protraction, she needed additional place for the canines. So we use the same mini implants now for our Bennett slider. And this is removal of the hybrid Hyrax and insertion of the Bennett slider. Again, use the same mini implants for many purposes. We call this multi-purpose use. And now the Bennett slider is doing the job. And now we have enough space for the canines. And this case was finished afterwards with buccal brackets. And you can leave the screws afterwards in the mouth. And I think she was running around with her mini implants for 3 years, just for fun. Okay, you can leave them. The kids are having fun with them. It's like a piercing. Yeah. So this is 3 years in retention, and it looks quite stable. After 5 years, she said, now I'm 18. Let's unscrew the mini implants. And this was a day where we have unscrewed them. So you saw the 2 appliances approach, hybrid Hyrax and Bennett slider. Again, use the same mini implants. We talked about the hybrid Hyrax distalizer at the first webinar. So I will show you these slides just very quickly. It's a hybrid Hyrax, but with additional distalization screws. Okay, hybrid Hyrax distalizer. Orthopedic protraction of the maxilla plus orthodontic distalization of the molar teeth. Moderate class 3 patient. The molars were rotated mesially plus moved mesially, so not enough dental anchorage for the expansion, for class 3 traction. So we used the hybrid Hyrax distalizer expansion maxillary protraction with a face mask, and after that, orthodontic distalization. Yeah? So now the patient is activating these screws, the distalization screws, once a week. And this is before and after distalization. And now you have enough space for the canines. The good thing, the patient can continue with the face mask treatment because the appliance is very rigid. We have distalized the molars, but the whole maxilla is coming forward. Okay, so it's now a class 2 patient, which is of course great. Yeah? And we spoke about this already at the first webinar. Do the difficult things with these kind of appliances, and afterwards finish the case with aligners. I think a very smart combination. Yeah, expansion, maxillary protraction, and molar distalization with the hybrid Hyrax distalizer. Afterwards is an easy class 2 case. Finish it with aligners. Yeah? So you see a nice improvement of the skeletal structures, width improvement around about 7 millimeters. Nice improvement of the profile. He was wearing a face mask. Of course, it is possible to combine the hybrid Hyrax distalizer also with a mental plate. Published in this paper, you see a severe class 3 dish face and a severe crowding. Not enough space for the canines. Okay, so treatment strategy: maxillary expansion, maxillary protraction, and molar distalization. Mini screws inserted. Now take an impression. This is the hybrid Hyrax distalizer. After expansion, you see the nice trema. Oral hygiene is not super. Sometimes we see these inflammations around the mini screws. This is more or less in those patients who are not cleaning the mini screws. So we are using chlorhexidine and we are motivating the patients to clean the mini implants. Okay, so now maxillary protraction with the mental plate up to 400 grams per side. So the maxilla is expanded. Start with the class 3 traction immediately. Okay, and after maxillary protraction, patient is now told how to activate the distalization screws. They are activated once a week. This is after distalization. You see now spaces in enough space for the canines. Hygiene is not so super, but we have expanded, maxillary protracted, and distalized the molars. Okay, so widths improved from -6.6 to -0.4, so quite a lot. A nice orthopedic improvement, nice distalization, and a nice result at the end. And of course, patients are happy, parents are happy if you see such a nice improvement of the profile, because you get a pure maxillary protraction and no dental migration. And this is, of course, what we want. Impacted teeth, impacted canines. Where can we insert the mini implants? He needed a hybrid Hyrax and class 3 traction with a face mask. If you insert them in the conventional position, there's a risk that you are touching and damaging your canines. So where to insert the mini implants? You can go a little bit more distally, as you can see right here. So this is a hybrid Hyrax in place. We have inserted the mini implants more distally. They're not in the suture, they're a little bit next to the suture. After rapid maxillary expansion, these are chains. The impacted teeth were surgically exposed. He's wearing now the face mask. And because of the situation that we want to align the impacted teeth, we added small tubes, as you can see right here. So again, my proposal for you, you can design multi-purpose appliances. So this is an appliance for expansion, maxillary protraction, and afterwards forced eruption of impacted teeth. And for this purpose, we have added these tubes, and we're using now these fishing rods, or lever arms for alignment of impacted teeth. So only the sky is the limit if you want to design these mechanics. Impacted teeth are now aligned. Patient can continue with class 3 treatment with a face mask. And now it's a normal patient. You can finish easily like you finish every other patient. Another idea for multi-purpose use. This young boy had missing central incisors. We used the hybrid Hyrax for rapid maxillary expansion and maxillary protraction, which has improved. Again, multi-purpose use. Don't unscrew the mini implants. Leave them in place for the second purpose, or sometimes third or fourth purpose, in this case, temporary pontics. And in this situation, they were very stable. This is after 5 years. Okay, multi-purpose use. Don't unscrew mini implants in the palate. You can use them for many purposes. This is another patient where we had some tongue thrusting. So he pushed the tongue during swallowing in between the teeth. Of course, you can go to the speech therapist to fix this, but after a couple of appointments, you maybe have to change your strategy if you don't see an improvement. And for this purpose, we are using spurs. And because he additionally needed expansion, we have used this hybrid Hyrax in combination with spurs. Okay, so you can expand and correct the tongue thrusting. Multi-purpose use of mini implants. Design your mechanics as you need them. How about the super severe class 3 patients? And this is the last growing patient I'm showing you. He has a severe retrognathie of the maxilla. So in those super severe cases, you can go for surgical distraction. Okay, so in this case, we planned the cut in the area mesially of the molars. And the idea was to get a distraction around about 10 millimeters. This is the distractor. It's an extra-roll distractor. So the cut is done by the surgeon, of course. You wait for 1 week, and then the patient is activating this distractor every day. Maximum distance, as we know, is 1 millimeter per day. This is before and after distraction. And you see, this was the original cut. Yeah, how much distance, how much new bone we have generated. Probably more than 10 millimeters. So this is for the super severe class 3 cases, distraction. You see a nice improvement of the profile. This is directly after distraction. This is after orthopedic treatment, orthodontic treatment. Patient looks now normal. Okay. So the last 30 minutes, I like to speak about RME and class 3 treatment in adult patients. Of course, we don't have any growth anymore in adult patients. So in severe cases, we need surgery. So floating bone after SAME, if you are doing, if you have a mild class 3 case, we always have to think about that we can use the surgical assisted RME also in the sagittal dimension. So we started with a rapid maxillary expansion with a hybrid Hyrax, applied class 3 elastics. You see the nice trema between the central incisors, and we call this floating bone. So if you have done these cuts in the LEFOR1 area, of course, not just expansion is easy, but also anterior movement of the maxillary complex. And you can move your maxilla maybe 1 to 3 millimeters forward. Floating bone. Skeletal retention. We spoke about this already with a bender plate. Skeletal retainer. And in this case, we had a little bit unilateral expansion. So another multi-purpose use. Constriction in the first quadrant. Never unscrew the mini implants. Maybe you can use it for the next patient, for the next appliance. And this is at the end of the treatment. And the maxilla came forward a little bit. I used to have many lingual cases, maybe 15 years ago. I shifted a little bit to aligners now, but this was an adult patient with a constricted maxilla, and she needed expansion. So we used the hybrid Hyrax, in this case, not with 2 mini implants and 2 teeth, but 3 mini implants and 1 tooth. Okay. This is how we connected with the incognito appliance. And this is after expansion. Skeletal retention, I'm doing this in almost every patient. And this is a patient after expansion. Another patient where we did lingual treatment, the quad expander. Nowadays, this was treated a couple of years ago. I think nowadays I would not insert the mini screws anymore here. I would insert them between 5 and 6, but this is the lesson we have learned. after expansion. And again, skeletal retainer. She had a gummy smile, so she additionally asked for surgery. Of course, you can use also high-tech in MACFAC surgery. We use these guides, CAD/CAM made guides, and this was the patient after surgical correction of her gummy smile. Patient at the end of the treatment. So in some patients, we need rapid maxillary expansion and distalization. We talked about the hybrid Hyrex distalizer. He was a class 3 patient who needed surgery, but before surgery, we always need decompensation. So in this case, the plan was rapid maxillary expansion and distalization of the upper teeth. Mini screws in place, hybrid Hyrex distalizer. Again, what is the job of the hybrid Hyrex distalizer? Expansion, and after that, distalization. So the patient is first activating this screw for activation, for expansion, and afterwards these screws for distalization. So this is after expansion. You can fix this expansion screw. Of course, you can try if the suture opens without surgery. I'm always trying this, but in many adults it doesn't. So we have to add surgery. Okay, so this patient, the suture did not open, so we asked our surgeon to do some cuts in the level 1 level. And after that, distalization. So the patient is activating these screws. This is before and after expansion and distalization. And you see the nice retrusion of the incisors. And now the patient is ready for surgery. The hybrid Hyrex distalizer can be removed after surgery in the finishing phase. A nice profile and a nice result at the end. Another patient, severe class 3, and she asked for surgery. Skeletally severe class 3, dentally a mild class 3. That always means there's a lot of compensation in this case, and if we want to go for surgery, we need decompensation. You can distalize, or in this case, because 1/5 was hyperplastic, we extract it. But if you extract the upper 5, you really need a good anchorage in many cases for the molars. What is the best anchorage for molars? We are using 1 mini implant in the anterior palate. 20 years ago, we had 2 mini implants between 5 and 6 or 6 and 7, but so many failures, and I was always afraid to damage a root. So my recommendation for you nowadays, don't insert mini screws between the roots. It has so many disadvantages. Okay, so keep it easy. Just use 1 mini implant in the anterior palate. This is by far the best insertion site. So nowadays we are using this triangle TPA. Why? We have an additional transversal control. So we are adding this posterior wire. We call this triangle TPA. And this is, from my point of view, the best molar anchorage device if you want to retract all teeth and if you want to really stabilize the molars in the perfect position. So from here to there, you need a really good anchorage. Yeah? And from my point of view, too many implants like the Koreans are doing it, buccally are not the best solution. So I think one mini implant in the palate is better. Okay, so now we have a big, nice overjet, and the patient is ready for surgery. This is the situation after surgery. We're coming now to the finishing phase after debonding, and please have a look at the profile. Now see, she is super beautiful. Yeah, why? Because we have evaluated the amount of compensation and we have decompensated a lot. So decompensation before surgery is crucial. It's always very important. Another patient where we have done surgery first. We are not so super enthusiastic about surgery first, but we do it in some patients. We do it in symmetric cases. So our recommendation, if you have a severe, difficult case with asymmetries, maybe surgery first is not the best way. But in easy cases, symmetric cases, it's possible. Okay, so again, severe skeletal class 3, mild dental class 3. What does it mean? There's a lot of compensation in this case. What does it mean? We have to decompensate before surgery or using the surgery first approach after surgery. Okay, so surgery first means we are first doing the surgery and after that we are going for decompensation. So we have put brackets on the teeth and immediately did the surgery. So patient is happy very soon. But you can imagine if you're doing the surgery so early, we have dentally a class 2. It looks like this. Yeah. So we have class 2 round about 5 to 6 millimeters. So now we have to retract the incisors. And for this purpose, we need a very good anchorage if we have an extraction case. Again, we are using the triangle TPA because it's very reliable. So retraction of the incisors, after retraction of the incisors, and this is the patient at the end of the treatment. So again, surgery first. You can do it, but my recommendation only in symmetric and easy cases. So we have published a paper about the triangle TPA and the advantage compared to conventional anchorage like a TPA. If you want to read this paper, you see a big difference between skeletal anchorage, much better compared to dental anchorage. Skeletal anchorage is more effective to a TPA. This is, of course, I think, common sense. Koreans are using 2 buccal tats. This is a patient of mine I've treated 20 years ago, but again, I don't like them too much anymore because of the reasons I have discussed with you. So at the end of my lecture, I'd like to speak about, again, the digital techniques, because in the future we are using them more and more for insertion guides and to CAD/CAM design the hybrid Hyrax. And since 2 years, we are doing this in our university on a regular basis and using these insertion guides. Maybe this can help a starter of palatal anchorage if you don't feel so comfortable and confident where to insert the mini implants. You can use these insertion guides. It makes you, I think, more confident. And another advantage, you can insert the mini implants and the expander in one appointment. So you don't need an impression after mini implant insertion. We are also using this in special situations. For instance, here we have a cleft palate patient, and if you have a cleft palate situation, you have always a problem to find a proper bone availability. So for this purpose, we are doing a cone beam CT, and this is a young patient with a cleft palate. Another disadvantage or problem of the cleft palate patients, they sometimes have a very thick soft tissue, and thick soft tissue is always a problem for our mini implants. The mini implants should be as much as possible in the bone and not so much in the soft tissue. Okay, so this is another reason to do a cone beam CT in cleft palate patients for our hybrid Hyrex expander. So this is a hybrid Hyrex distalizer in a cleft palate patient with quite a class 3 style, but she was wearing it properly. You see a nice improvement of the profile. We distalized a little bit to get enough space. We measured the wear time, so she was wearing it very properly. Yeah, you see the huge amount of the changes of her profile. This is the advantage of the hybrid Hyrex. Again, no dental side effects. The results that we see are only skeletally, and this is why I'm strongly recommended to use it if you have young class 3 patients and you want to get as much skeletal response as possible. So these are the insertion guides. Today we are also printing the appliances. I think I have mentioned this in the webinars before. And you can use the scan bodies if you want to. Depends on the scanner you are using. And nowadays we are designing the appliances with a CAD/CAM procedure. This is, for instance, a patient where we used lingual braces and we are connecting the wires with our lingual bands. So the advantage, we only need one appliance and we can do expansion and leveling of all teeth simultaneously. Years before, we had to do expansion, wait for 6 to 9 months, and it can be fun. This is a video I received from Denmark, a technician having fun to manufacture a hybrid Hyrex distalizer. This is Star Wars music. So you can design the mechanics as you want them to. So we're coming now to the take-home messages. We can do RME and early class 3 treatment with the hybrid Hyrex. I think it is very recommendable. We see less dental side effects in the sagittal dimension, but also in the transversal dimension, less tipping of the teeth, and in the vertical dimension. So the risk of bite opening is lower as well. This is my turbo for early class 3 treatment, and I strongly recommend to do this. Yeah, if you have a young class 3 treatment patient and you want to avoid a later surgery, this is the best chance to avoid it. This is a turbo for early class 3 treatment. Hybrid Hyrex, Alt-Ramec in combination with a face mask or a mental plate. Width changes are up to 9 millimeters from our clinical experiences. There are intro alternatives to the face mask, such as the bollard plates. However, failure rate is, from my point of view, too high. So I strongly recommend the mental plate. Failure rate is 0. The only problem we saw from time to time that this hook may break. Yeah? So we have to be aware that we don't bend it back and forth too many times because it's made out of titanium, and if it breaks, of course, it may be a problem. Okay, so this is the only problem we saw using this mental plate. It's for those patients who don't like to wear a face mask and the vertical patients. I think digital technology can help us if it comes to the insertion guides and CAD/CAM design of the appliances. And this is our website. If you want to see some more, we have many papers there for free download. If you take a scan of this QR code, you will automatically find this website from the University of Düsseldorf. I've mentioned this before. This is the dealer of the benefit system in Russia, Dr. Jana, and she's a very smart doctor. So if you're interested, you can contact her, and I think she can help you as well. At the end of my lecture, I like to invite you to visit us in Düsseldorf again. I did this in the 2 webinars before. We have many guests from all over the world, from China, from Australia, and so on, and direct flights from Moscow, so it's easy to get to our department. We also have once a year a very nice meeting, and I like to invite you to this meeting as well. It takes place next year in June, and we have Marco Rosa there, one of the world leading speakers. He's doing a pre-congress course about space closure and the upper arch. Marco Rosa is using the mesial slider. We talked about this last week, and we are very much looking forward to this nice meeting. If you want to try the digital techniques, there is a Tedman company, and you can have a look at this website. We have insertion guides, CAD/CAM insertion guides, and CAD/CAM appliances, and you can send us a scan of the upper arch, and you will receive insertion guide and the appliance, and you can insert both in just one appointment. I think this is the future of mini implant technologies. So this is my email address if you want to contact me. I'm also you can contact me also on Instagram, Facebook, YouTube, or I think even LinkedIn if you have some more questions. And yes, at the end, I'd like to thank you so much for your attention. And sorry for my cold. Hopefully we'll be better in 2 weeks when I'm speaking about pre-prosthodontics. That means molar uprighting and molar intrusion. I think also very helpful device if it comes to adult patients with pre-prosthodontic treatments. So have a nice evening and see you in 2 weeks. Bye bye. Thank you.